Risk prediction scores are not perfect, not today, and despite all the time that we've been doing that. And who best than this guy, Professor Joseph Caprini, to tell us a bit more about whether that is true or not? Joe, through the whole many 50 years you've been with the score, tell me the key moments in how it was developed and what do you wish for it to be improved still?
Well, the key parts of the development really include a very, very important article by Maxwell Borrow, who used venographic endpoints and studied over 1,000 patients, showing that there was a relationship with not only the risk factors that occurred for venous thrombosis, but the power of the risk factors. Age over 40 was one level. If it was over 60, it was increased. If it was over 75, it increased. Same thing with the type of surgery. But the really key thing, which is still missing today, is the fact that he showed if a person had a previous history of thrombosis and they didn't have prophylaxis, they would get another thrombosis going on. And today we have a problem with people asking the question about family history, which is also related to what Borrow studied. So, armed with that, and then surrounded by some very brilliant people, we came up with a score. And in 1991, we studied 1,000 patients and showed that it worked in the hospital to show which patients would benefit from prophylaxis. It took till 2010 for it to be formally validated, which was done in an 8,200 patient study in the University of Michigan. And since that time, it has been gradually adopted. But some of the problems that exist is, first of all, we still don't have a good handle on how to ask that family history of thrombosis because it's still missing. And the other really big problem is that there's a whole host of factors that have been introduced since the original score. Let's say in the blacks, sickle cell, and in the Mediterraneans, Italians, thalassemia. These are risk factors for thrombosis. And there's HIV, there's blood transfusions, there's diabetes requiring insulin. There's a whole bunch of factors, and you can't keep going back and validating the instrument. And so now what we have to do is we have to find better ways going forward to validate the instrument. Artificial intelligence is one way, but one of the things that's a problem now is taking this risk score and embedding it in the electronic medical record because there's no physical exam. And again, patients still are not quizzed about family history of thrombosis.
So, what I'm hearing is some statistical power may be included. That's where AI probably starts improving, but still the actual things that we capture are incomplete. Now, let me postulate this idea in which maybe machine learning has become, or the computer power has become smart enough to keep adding extra layers, just as if it was a beautiful onion soup. So layers statistical based on the data, but I can train the computer to understand physics. I can train the computer to understand hemodynamics. I can train the computer to start capturing your wearables, to start capturing what you're doing, your environment, so that can also be thrown into score, limiting these kind of variables that you tell me are not there yet. And then we will transform static scores into maybe digital twin technology. This is going to be the core of the lecture we're going to share in a few minutes. In my view, we're trying to get past a mirror in which I simply explain what I see as far as risk factors and develop a crystal ball where I can modulate new truths based on machine modeling and digital twin technology. So we don't have to repeat yet again and again and again all of this discovery that you nicely did so many years ago.
Yeah, yes. So I think that's the next step. And you see, there's Alex Spiropoulos with the medical patients has done a marvelous job on the medical side, showing the same kinds of things that I've been showing on the surgical side. But it's all very primitive if you really look at it. And using these additional tools and incorporating hundreds maybe of factors and their powers and maybe doing, thousands of simulations to test these models, which we can all do now, and you're going to describe in your lecture. I think that's the wave of the future, and that's going to bring us together. There's still an Achilles heel. You cannot take the human being out of the equation. Somebody still has to look at the leg. Somebody still has to talk to the patient and ask questions that weren't properly understood by the patient. That's the Achilles heel. But I'm very excited about your new approach.
Well, let's see which are the pros and cons of these additional ideas. I think we do agree what we have is not perfect, but we also agree that we can see a future because we have new tools. It's time to use them. Let me go ahead and explain a little bit more about this idea of how this has been evolving. And we'll use, of course, the Caprini score as one of the models of this to happen. Let's go from precision medicine and peel the onion. I kind of alluded to that idea. And let me explain why. So the things that I'm going to be discussing, besides the idea of just putting that nice picture that my wife made for me, is going through this pattern of the times in which we were using static scores, then understanding a bit more of the addition of additional mechanistic biomarkers information. Where are we on the age of genetic information in precision medicine, which I would argue with polygenic scoring, we're much more advanced nowadays. But ultimately, there are so many variables that we need a special type of intelligence, if you may, to actually put all of that together and go beyond more simple constructs of prediction. And finally, in what I would have called the future, but it's probably the today, what can we do as far as digital twins into better prediction? So on this analogy, I remember my grandfather way back when diagnosing a patient just by looking at them because that's all he had, examination of the patient. But from there, we have much more advances that it's now irresponsible not to use them to the benefit of our patients anymore. On that note, I have this layering analogy. And the reason that I like this analogy is because you need to, if all of you have done a onion soup at once, it was a very cold day today, actually. And I can tell you, cutting it, letting it caramelize, then putting these extra flavors, adding layers is a nice analogy to this idea in which we have to understand basic principles, add additional substructures of putative variables and data, inject these external magic broth to actually re-include and let it simmer all together before we usually can develop and actually validate a new score. On that scenario, let me split specifically venous thrombosis in before the clot and in after the clot, because of course we have different problems that we want to solve in those two different scenarios. On the before the clot, we know there's age, body habitus, sex, comorbidities. We know that all of these variables actually matter. And as you mentioned, when you put them into a construct and understand that each of those may actually have different amount of weight on the possibility of developing a blood clot, then we are after something. We have generated a prediction model. Is that the best we can do nowadays? Well, I would argue there's more specific ways to integrate the data of the patient. We have, let's say, wearables. We have non-wearables. We call them invisibles, which are ways in which the technology can actually analyze the patient even without touching it. Sounds like sci-fi, I know, but basically there's a bit of a Doppler effect on the Wi-Fi waves that are hitting us, and that can be reanalyzed to actually absorb information of the patient, which now can be integrated. So the future should be looking into all of those variables to refine the scoring product. So, but then again, this epidemiological information has its problems. It's definitely imperfect, and I know that you will agree on it. we have, let's say, cancer and thrombosis as one of the main scenarios in which we have problems. So let's argue Khorana is perhaps the best validated. And I'll be the first to say it's definitely not a perfect score. We can have, let's say, a compass cat also. But in reality, no score is really truly perfect yet. We have your score, Joe. Let's say in medically ill patients, I would argue the improved score has an edge. But let's be a bit more specific about how good are they. If I had a patient, and if you are my patient, and I'm going to tell you, you know what, I am going to do the best I can, and still I'm going to be wrong, let's say about 3 out of 10 times, on really understanding that you actually need this medication to help you, and that I'm certain that you're going to be the one who actually does better with my decision process. So we walk as if we have this level of certainty, but we need to humble down and understand that the level of certainty we have is lesser. If we do a meta-analysis on the multiple types of scoring systems, and let me pick this up a little bit, scoring systems that we can have on some patients, you will see that you stand strong with many millions of patients already validated to the score, but there is some compromises, as you see, on the sensitivity and specificity. And we can argue all day that some of the scores are yet to be better validated, and yours has an edge, but it's time to look beyond, is what I'm arguing. How do we look beyond now, not in the patient who might have a clot, but the patient who has already had the clot? I can tell you, out of the patients that I see, there's not one day that passes without having at least one of them tell me, well, doc, can I actually stop my medication now? Even though we have discussed this 1,000 times. And based on the best information that I have to tell them, you know what, your likelihood of recurrence is still high because we calculated, let's say, the HER2, Vienna or DASH, or a combination of all of that as you did back in your days. But for instance, just with this example, HER2 score, the true name is men continue HER2, right? So basically the whole scoring system does not work to predict 50% of the population, doesn't predict men well who have had an unprovoked event. So that's a problem, because it means that we are not yet at a granular level that we're able to help more patients with our analytics of prediction. So that is where we are as far as scores. Let's argue about this one that was recently published in the VTE registry. So abstracting almost 18,000 patients, we reevaluate. And again, it's like these 0.7C statistics, so far from great, on trying to discriminate the VTE predict scoring system. Now, what happens here is that you can see that the lines actually separate such that there is some level of prediction. Actually, if anything, the rates actually separate, but I would argue it's still a good score. Interestingly, amongst patients who are going to discontinue the medication, the rates of the C statistics actually drop significantly. So this is limiting. This still tells me that there's much space to improve when we evaluate the true prediction of the multiple scenarios of how to control the risk and benefit of the patient who's chronically anticoagulated. Do we have these in multiple other shortcomings? If we continue to evaluate the patient in longer amount of time, which, as you know, I mean, we can follow these patients for much longer, on repeated measures of likelihood of recurrence, we will have even lower reevaluation of how these scores predict, because there, if anything else, seem to be lacking this feedback loop into re-understanding that life has changed and these patients may continue to acquire other risk factors for bleeding or for clotting, or sometimes maybe they lost a lot of weight, so that their risk factors have modified for the better. Or there are better medications to control their IBD, for instance. So all of those variables are not being considered on the best we have to date. Can we get a little bit smarter with, let's say, biomarkers, which for the most part, there's very few scores that actually introduce state-of-the-art biomarker evaluation nowadays. And we can consider biomarkers from the clotting perspective, the inflammatory perspective, adding a layer of genetics. So let me explain a little bit more about the pros and cons of those aspects. I remember you using pretty much all of these all the time. I should say we should argue von Willebrand here as well. To understand additional predictors of this patient to have blood clots. Some of these are going to be difficult to replicate. Some of us don't really even have access to full-time laboratories that are going to give me all of this. Some of these variables actually change in time, change in repeated measures. And that is what adds to the problematic of using biomarkers. They have different meaning, they have different type of laboratory standards. They vary with age, they vary with inflammation. So even though they help us a lot, there's this transfer towards the meaning, which some of them are going to be less useful for me to understand the patient. So granted, adding biomarkers to my risk stratification helps me on my everyday practice, but I would argue, again, the mode here is maybe we can do better. So now we're actually saying we have this temporal variability, the acute phase reactant dependency, the impact of anticoagulation, and even so different kinds of anticoagulation. For instance, you're aware that the behavior of a beta dimer is actually different depending on a patient being anticoagulated on warfarin versus anticoagulated on a DOAC, and yet that's one of the variables that is very heavily weighted in the HER2 score, for instance. So how do we bypass this? Sometimes ways to maneuver epistemological uncertainty is to add more data. So trying to look into other variables in which they can actually help me understand the truth. To that end, I actually go to evaluation of genetics. And now it took billions of dollars to do the first genome, but now we can replicate a whole genome for $400, right? So now we're no longer having to look just into, let's say, a 5 line and just into, let's say, proteomic mutation. I can do a whole genome analysis, analyze 270 plus SNPs, single nucleotide polymorphisms, and actually create a polygenic risk score in my real practice. I mean, this is something I am actually doing with some relative frequency, I would say, already. And I'm lucky to have a whole system within my institution that has genotypes, several thousand people, so that we are sub-selecting those who might actually benefit from reporting actionable results. How does that work? So we published this paper not so long ago, in which we did a validation of polygenic risk scoring in a UK Biobank, then in our own database, to make a combined score with our PRS, and it ended up improving the net reclassification. Now, this does not mean that you will have a clot, but definitely those in the highest percentiles have a significantly higher risk, well comparable with, let's say, having been born with a factor V lining or such. So those patients need to be educated, and we have these powerful approaches. How would I use it? Maybe one of the better ways in which I figured out how to use it is on this one. So this is a recent manuscript that we published. Basically, we know that, let's say, Khorana does not really work that well in differentiating patients with lung cancer. So what I did is we selected over 3,000 patients with lung cancer from UKB. Then we evaluated how would polygenic risk score evaluate them, and then evaluate whether that, after sub-selecting for all of those acquired risk factors, would still be a helpful predictor for thrombosis. And the answer was yes. So basically, amongst patients in whom have a intermediate risk cancer for blood clotting, like lung cancer, adding this additional layer of the onion, if you may, helps me differentiate the ones who would have a risk high enough that it's a true valuable discussion to have. Maybe I want to do primary prevention with these patients. So that's how personalization of care can keep on helping me, all the way from scores to integration of biomarkers to yet another layer. And I'll let it simmer into what may actually come next. So interpreting all of these effects is still not perfect. Now, why do I say it's not perfect? And basically, the polygenic risk scoring have well been validated in millions of patients, but yet the databases are succinct, and there's very few databases that have integrated diversity of ethnicity and diversity of color. So there's concerns on that. Also, some of the outcomes are based on billable data. So we know that, for instance, a pulmonary embolism on a database, the and that is absorbed by coding only, sometimes it doesn't have the true specificity of its value. So there are restrictions to all of these validations that have been done. It's good because it's stable lifelong, right? And we're not planning to crisp anybody right away for many of these SNPs. It gives me, if you so want to, some mechanistic insight into what things are happening. It may actually, in the near future, help me go into new strata of medications, but it's not going to explain it all. And remember that after genetics, we have the epigenetics, we have the patient behavior, we have the other things that happen. So it's just one more layer that we have to carefully intertwine with everything else we know about the patient. And that's when it gets really hard, because back in your days, you were genius enough as to create a construct and put a lot of variables, 40 variables into it, as to say, well, this patient is more or less likely to clot. But now I'm throwing at you more variables, and now I'm throwing at you more data, and now I'm throwing at you real-time information. That's too hard to put into a single construct. So enter artificial intelligence to help me understand the more complicated and real-time statistics with a better computer power so that I can actually integrate or try to make sense of this all. How successful is this right now? Well, in reality, the area under the curve of many machine learning algorithms will be better than the static scores that we have been using for some time. So is that perfect? Well, of course not, otherwise we wouldn't be having this lecture. So let's examine one specific here. So this was a paper I was lucky enough to participate on with some colleagues from Beijing, in which the area under the curve was superior, quite honestly, and prospectively evaluated Caprini score was actually done on these patients. And again, the AI generated was importantly valid. Let's look into what was done. So in the derivation cohort, there were 1,100 patients with and 1,100 patients without thrombosis. Every single patient in the hospital had a venous ultrasound. You can imagine the actual investment for that to happen. That helped the derivation, the internal validation, about 3,000 patients. Again, same thing. Everybody knew that they did or did not have a thrombosis, and then external validation. Long story short, the area under the curve was superior, and the area under the curve after external validation was important. These are some of the top ML predictors. The problem I still have with this, for instance, is that it's not 100% implementable. We need to validate in other institutions, and we need to let it simmer and cook with different kinds of practices. For instance, we have an analysis on VTE in which one of the more important variables was where is the patient treated, because we do have different cultures on how we treat patients, regardless of how the variables are embedded. So external validation is still pending for many of these ML scores. We have to avoid other factors like black box evaluation. We need to have explained AI, I would argue, for most variables, but it's making a stride. Can we now make all of these systems smarter? My argument would be yes. We are definitely seeing an avalanche of products and new evaluations. And that is also a blessing and a curse in the sense that maybe there's too many, and ultimately it's going to be delayed because of lack of implementation. But we can now reintroduce more sophisticated statistics into the applications. Where are we seeing some of these? Well, indeed, in risk prediction. As you know, there is a simplified AI in our institution in which the Caprini score is measured real time. I would argue there's some benefits to it, but integration on EMRs for clinical decision making is a reality in many institutions already. It can make us detect images with facilitation. Can even start helping me understanding which is the patient who might be safest on one medication versus another, or to control evaluation of outcomes. So AI is here to stay. We still have to adapt to integrate it. And it's amazing to me that it looks as if it's actually new, but when we really humble down, it's already past if I start considering the new ideas that are coming already. Beware of the black box, beware of the data set biases. I mean, Joe has been very strong on opining about this, with rightfully so. Many of the databases are made for billing. They are not made for capturing true information of the patient. And there's some variables, like for instance, you will be strongly advocator of making sure that the patient's family history is somewhere in the chart, which is a strong predictor of thrombosis. And yet we don't even know how to ask the question right sometimes, right? So examination of the patient, I would argue that eventually we will arrive other methods to bypass that and then integrate physical exam on invisibles, for instance, but we are far out from it. That is embryonic technology yet still. Validation is very important in AI, and I think it's still going to become a problem because there's been an insufficient sharing of methodology on this aspect, and it's very easy to capture overfitting and then trying to ignore the fact that sometimes variables missing not at random are actually included in databases with some dangers of interpretation. Passing from that, let me see if we can reframe this idea. So, because in reality, we have a very good mirror. We have a very good way of evaluating what is in front of me and using any of these methodologies or combine these methodologies, logistic regression or XGBoost, etc., to have a much more sophisticated evaluation of what is in front of me and gets closer to an adequate prediction. There's a lot of things that AI can still not do. So for that, if I were to recommend you, there's a fairly new book by Cass Sustain. Precisely, the name is Imperfect Oracle, telling us the things that we still have to improve the AI utilization. And yet, it's probably an old technology already. Where am I going now? I'm going to the idea that perhaps the true present is looking into something like going from the static scores to dynamic simulations. I had this patient last week, and she has, homozygous prothrombin mutation. She has a polygenic risk score of 97 percentile, and she has a BRCA positive. So they want to give her raloxifene after her breast cancer surgery to inhibit further the risk of clotting. And then they send her to me for me to estimate what is her probability of clotting. And is it really warranted to actually do all of this, given her predisposition to thrombosis? Those are too many variables, I would argue. And I can do it probably manually and then just start calculating, well, the baseline risk of a female this age is going to be close to 8% in lifetime, plus she has the homozygous, plus she has this. Therefore, the rough calculations on risk, but I don't have enough mental power to calculate all the permutations of her true history on risk and benefit of her addition of raloxifene. So what I did with her is I talked with her. I understood which are her biases on what she really wants to protect versus not. So key, the patient needs to be included on the decision making, of course. But then I did a Monte Carlo simulation with all of the best information I could find about all of these variables. And I did a 1 million cases Monte Carlo simulation to understand which are the potential futures. That information is already available to our patients. That is already relatively easy to do, I would argue. So it becomes irresponsible from me not to give them the best I can to make a decision. How does digital twin become part of the care of my patient today then? So in the digital twin world, within the cardiovascular environment, so let's imagine that we have a biological layer. So let's imagine for a second that I can introduce all of that genome into the computer. But then I'm going to teach my computer, my system, what is the territory where this patient lives. So now I'm going to know that where she lives, there is X, Y, or Z type of that many parks, the safety of the environment, etc. Then I'm going to intertwine her true behavior. Then I'm going to say, this is a patient who is very active or not. She has a wearable that has tachycardia. And then I'm going to add to the machine another layer, let's say, about physics. So as you can see, I have so many layers in this onion that now I can make the system much smarter to understand things beyond the simple database that we have used for so many years as to be the know-it-all as far as how the patients will behave, which is not true. There are many other environmental and physical layers that the machine can understand. With that, we create basically alternative futures in which I can now model from the data acquisition to the training, the creation of simulations. Then finally, I can give the patient a much more individualized feedback of which of the alternative futures the he may actually have. This sounds like sci-fi. It's not. This is actually the present. It's not in the future anymore. How am I actually arguing that this can happen? Well, we can inject these models, then have patient-specific data, then in the background actually compare with several digital twins. In the digital twin subterritory, add potential management behaviors that I can give the patient to understand within this equivalent twin, which is the one who's going to have the best luck out of what I'm going to do. Okay, so that's the way it actually starts working. How does it compare to artificial intelligence? Because let me make sure that I differentiate. This is not artificial intelligence. This is something else. Artificial intelligence, my best analogy to give you is that it takes the static version of it and puts into a biological system of systems, so which is actually smarter on the things that it can do. My best analogy here is I'm transformer a mirror in which I'm able to simply see myself and see the actual facts. With AI, I'm going to have a lot of definition, let's say, on the picture, but ultimately it's just a mirror. Whereas in the digital twin, I can actually have a crystal ball. I can understand what may happen if, and then associate multiple scenarios so I can actually reinform these patients. That's probably my best analogy. Let's dig a bit deeper to understand what is actually happening here. So with this same model that I just mentioned, so I do deduction and induction within the machine, which has been fed not just by data, but not just by the database, but also by information and more sophisticated information. Now it can split, let's say, how is the heart going to behave? How is the likelihood of having a recurrent thrombosis in an unusual type of location? How is the heart architecture going to manage the hemodynamics of an atrial fibrillation heart when I have done an ablation versus not? Those are the kind of information that this can give me now, so that the digital twin can further inform me even before I actually do a procedure. How is this applicable in the specifics of venous thromboembolism? Is it true that we can actually do better responses to my patients? So can I tell my patient, you know, Jane, now you should no longer be anticoagulated with the full dosing. I'm going to give you less. Not just because we have some information, but because I'm understanding that this risk-benefit ratio has broken precisely today at these real-time scenarios. So how do we dig deeper into this as a possibility? This is a study that was already published last year. Basically, it's looking into a simulation of unusual site thrombosis. And short of RIETE, which will have thousands of patients, in this study, they had barely about 90 unusual site thrombosis patients. They did a CGAN evaluation. So in not so many words, imagine Joe is working against me, and then let's say he's playing backgammon for matter, or let's say that he's making it simple. Let's actually say that he's trying to fake a $1 bill, which he would never do, but let's pretend. And then I'm the agent that is trying to say this one is real, this one is not, and I look at the first one and I say this one is fake. No, this one is fake. But he gets better. Every time I give him feedback, he's getting better. And then by the fourth, fifth time, I actually see this one and I go, okay, this one is real. That's what the generative adversarial networks are doing. So basically, imagine two AI systems fighting each other so that they can actually generate good new patients that actually have baseline characteristics of the initial database. Then we can do a Monte Carlo simulation with all of those individuals and basically replicate alternative truths as to understand what is the chance, let's say, as in this case, of recanalization by different drugs. Can we go any deeper? Well, there's a study that I'm not putting over here in which, let's say, the randomized controlled trials are limited by the inclusion and exclusion criteria, right? So I can replicate an randomized controlled trial, now creating digital twins that resemble much better what my true patients in clinic are, and then reevaluate in extreme scenarios on how much does it remain true that this medication or this action is actually going to help my patient. So that is also a simulation that is already being done. In this specific, I'm really interested in this one. For instance, again, the adversarial network was the main model, but what it's trying to do is evaluate patients with antiphospholipid syndrome to see which of the agents are going to behave better. But it's actually feeding the machine with not only data from a prior database, but it's also helping it understand, let's say, how the coagulation factors work, how is the medications actually working. So that helps it refine the opinion, if you may, about how the behavior is going to happen. And then, of course, gets compared. For now, it still gets compared with other dynamics. After you do the CGAN, many of the modeling within digital twins are using these DAG, so directed acritic graphics, which essentially are going to help me evaluate the connections of what things are happening one at a time. So it gets me closer to a causality understanding, right? So because it tells me B cannot happen without A 100% of the time. Well, therefore, one actually depends on the other. It's not just a confounder. From this modeling, let me try to summarize on this little table over here as to understand which are the advantages that we can now encounter. I'm not gonna say that one is 100% better 100% of the time than the other. I mean, I think all of these historical processes still have value in itself. But I would argue also that as we see this table, the digital twin is quite promising on being the one that is going to help me truly grasp precision vascular medicine in the present. Finally, I think this figure says most. It's really about integrating into a single scenario multiple things, not only the initial database that we have been doing for many, many years now. So the old paradigm is much more static. It has to only assess every so often, whereas the new paradigm may actually have real-time feedback, and I can integrate many more variables around the daily life of my patient that right now we're missing out on not being able to understand, quite honestly. This is not perfect, so I'll leave this simmer in the screen for a little bit. So it still is possible that digital twins may actually go into overfitting. We will probably have some cultural resistance as to what's the true value of this generation. These models will still need to depend on large databases to be created and then to be validated so that we can understand their true value for implementation. There will be, of course, some ethical concerns on how we maneuver the algorithms for them to be democratized. Because this should not be technology just for a few. This should be something helping the most. And then it's going to be calibration, of course. So these are some of the potential things that we have to think about as we move into this new territory. One of the better books on prediction that I remember reading was this Super Forecasting, which I do recommend it, on looking into many ways in which we can fine-tune futures. And in a much more simple summary, people who are right most of the time are people who change their minds very often, says Jeff Bezos. Well, digital twin is able to help you change your mind multiple times in a much more educated way and real time for the benefit of your patients. This is a tall order, but that's what we're here for. We are here to dream big. All the Swedish system is trying to create a digital twin for every single person in the country. And what that is the kind of goal that we want. We want to be bold and say we are going to improve the next few years. Finally, a true personalized care of my patient who might have a clot, let's say after surgery, or a patient who had a clot and I want to stop their anticoagulation. So with that, I end. I thank you very much, Joe, for making this happen. And let me be the vascular GPS. That's what I want to be, your vascular global position system. And avoiding the maps that we used to have so many years ago, we can do better. We can actually have technology help us guide our patients real time today, much better than we did before. Thank you much.